How to take blood pressure manually. To do that, first perform the hand hygiene. Make sure the patient has arm at their heart level and sitting with their legs uncrossed. Now if the patient is lying down, make sure the arm is at their heart level. Make sure to have a right sized cuff because it might throw off the reading if it's too tight or too loose. First thing we are going to do is to palpate the brachial artery. We will put the cuff on patient's arm 2 inches above the bend of the arm. First, we want to estimate the systolic pressure, so we will first take note of that number. To do that, we are going to palpate the brachial artery and will inflate the club until we can no longer feel the brachial artery. Make sure to note the estimated systolic number. Now, when we are taking the blood pressure, we'll inflate the cuff 30 mm of mercury more than the estimated number. The reason we are doing this is to avoid the oscillatory gap that can occur in some patients, like patients with hypertension. Now we'll inflate the cuff while feeling on the artery until we can no longer feel the artery and note the estimated number. Now we'll deflate the cupped hand and wait about a minute before taking the blood pressure. Now put the diaphragm of the stethoscope over the brachial artery lightly, then inflate the cuff. Then let it deflate at 2 mm per second. And note the systolic number, that is the first sound you hear, and the last sound, that is the diastolic pressure. Once done noting down the numbers, make sure to deflate the cuff totally.
Examination of the eye. The picture showed here is of a Snellen's eye chart. We'll begin the eye examination by assessing patient's visual acuity using the eye chart. We'll have the patient stand 10 to 20 feet from the chart. Having covered one side of the eye, ask the patient to read smaller lines of letters until they can go no further. And we'll be doing the same for both the sides. Next is assessment of visual fields through finger wiggle test. In this, we'll ask the patient to look directly into our eyes and respond with yes when they see the wiggling fingers. Through this, we can map out the maximum lateral extent of the left and right monocular vision fields. Next is inspection of the eyebrows for their amount, distribution, and any kinds of lesions, as well as the inspection of the eyelids for any kinds of swellings, edema, and lesions. Next is palpable fissure. So palpable fissure is the opening for the eyes between the eyelids, and we can assess the palpable fissure by asking the patient to look straight ahead and describing if that is normal, widened, or narrowed. Next is lid lac test. With our finger as a target in the midline above the eye level, move the target in downward, watching for appearance of white sclera between iris and upper lid margin. Next is for the assessment of conjunctiva and sclera. We'll ask the patient to look up as we depress both lower lids with our thumbs and to look down as we pull the upper lids upwards. For this, we can describe the color of the sclera and palpable conjunctiva. And now this is for the cornea. We'll shine bright oblique lighting and we'll inspect for the transparency, clarity, scars, abrasions, and ulcers of the cornea. Next is pupillary light reflex. For this, we'll darken the room, shine the bright light obliquely into each pupil, look for direct reaction consisting of pupillary constriction. Next is accommodation reflex. For this, we'll ask the patient to look in the distance, then at the tip of their nose. Next, for extraocular movements, we'll ask the patient to look to each side up and down following an H pattern. Also ask the patient to follow a target with their eyes without moving their head. Ophthalmoscopic examination. We'll begin by looking at the ophthalmoscope. Here is the practitioner side of the ophthalmoscope showing the brow rest, viewing window, diopter dial, diopter power display, and on and off switch. Next is the patient side of the ophthalmoscope showing the viewing window, filter switch, aperture dial, diopter dial, and a rheostat. Ophthalmoscopy, it is a test that allows health professionals to see inside the back of the eye called the fundus and other structures using a magnifying instrument, that is the ophthalmoscope, and a light source. It is done as part of an eye examination and may be done as part of a routine physical examination. It is used for the assessment of ocular health, posterior eye, and can also be used for anterior eye. Here is the picture showing ophthalmoscopy. A direct ophthalmoscope produces an erect image of the fundus. The examiner here views the patient's right eye with his or her own right eye so that their noses do not interfere with the examination. The examiner's right hand rests on the dial of the ophthalmoscope to bring the retina into focus. Next is, here is the ophthalmoscopic view of the eye showing the optic cup, optic disc, artery, vein, fovea, and macula.
Wash your hands.
After washing your hands, introduce yourself to the patient. Hi, my name is Nishpa. I'm second year student. Can I know your name and age, please?
Myself, Vishwamasi Golamanda. I'm 21 years old.
Okay. Today I'm going to examine your ear. Is it okay with you?
Yeah, sure.
Beginning of the ear examination, inspect the auricle. So for inspecting the auricle, check for any deformities or any lesions, skin lesions, lumps, any lumps. Then if you're feeling any ear pain, just tell me.
No.
No, there's no ear pain, right?
Yeah.
Okay. Then any redness, check for any redness, inflammation, and press the tragus. Move the auricle upward and downward. Then press behind the ear. Then for examination of the ear canal and eardrum. For the examination of the ear canal and eardrum, we should use the otoscopy with the largest speculum. Straighten the ear canal. Then pull the auricle upward. Pull the auricle upward, backward, and slightly away from the head. Then raise your hand against the patient's face. Fold the otoscopy handle between the thumb and fingers. Brace your hands against the patient, just like the previous one. Auricle and move the auricle upward, backward, and away from the head. Test for auditory acuity. Stand 2 feet behind the patient. Please repeat the letters and numbers after me, which I will tell you.
3. I. U.
Same with the other ear.
6. 5. 8.
Strike this tuning fork and place near the midline of the head, and please tell me whether you can hear the vibration.
Yes, I can hear the vibration in both ears.
Okay. Renee test. Strike the tuning fork and place near the mastoid bone, and please tell me when it stops.
So,
Okay. Can you hear?
yeah, I can hear.
Now I am performing the examination of the mouth and the oropharynx. Now I am inspecting the lips and observing the color, moisture, lumps, and if there are any ulcers. Now can you open your mouth? I am inspecting the buccal mucosa and checking if there is any pigmentation seen, any patches and nodules. I'm checking if there's any looseness in the teeth, their discoloration, if there are any fillings. Okay. Now I'm observing the color of the gums, if there's any swelling, bleeding, or if there's any pus in the gums. Okay, now let me inspect the roof and the floor of the mouth. Can you open your mouth? Okay, now I'm looking for any color, deformities, lesions or any masses. Put your tongue up. Okay, I do not see any lesions or masses with this patient. Now let me inspect the tongue. For this I am using gauze. Could you please open your mouth? Stick out your tongue. Okay, now I'm observing the size, the color of the tongue. Also seeing the moisture, the surface of the tongue, and if there are any lesions present. There is no redness seen on the surface of the tongue or at the sides of the tongue. Now let's inspect the soft palate and the pharynx. Can you please open your mouth? Okay. Now can you say Okay, to get a good visualization of the pharynx, you can use a tongue blade. Now can you say Okay. Now we have to note the rise of the soft palate, which rises symmetrically. Okay, let's do it one more time. Can you say Okay. We need to note that the uvula stays in the midline, and this is actually a test for the 10th cranial nerve, which is the vagus nerve. Inspect the soft palate, the uvula, and the tonsils. Okay, I'm also checking the posterior pharyngeal wall and noting the color and symmetry. Also, if there's any swelling seen, tonsillar enlargement, and ulcers.
Okay, now I'm moving on with the examination of the neck.
I'm inspecting the neck to check the symmetry, the size, the deformities, and if there's any swellings or masses. I'm also observing how the patient carries his head, if it is tilted or rotated. And let me palpate the cervical spine, the mastoid process, the trapezius, and the sternocleidomastoid. Palpate the trachea for any deviation from its midline position. I have to place one finger along the side of the trachea and note the space between it and the sternocleidomastoid. I have to compare it with the other side, and this has to be symmetric. Preauricular, posterior auricular, occipital, tonsillar, submandibular, submental, superficial cervical, posterior cervical, and supraclavicular. Inspect the thyroid. Can you drink little water when I ask you to drink?
Yes.
Okay. So when the person swallows water, we have to note the ascending mass in the midline. Can you drink now? Just sip. Take a sip. Okay. Now can you swallow? Okay. When the person swallowed, the thyroid gland, the thyroid cartilage, and the cricoid cartilage all rise and they fall back into the resting position. Palpate thyroid. So for this, I have to stand behind the patient and I have to place the fingers of both the hands on the patient's neck in such a way that the index finger is just below the cricoid cartilage. Now can you sip some water?
Yes.
Have a sip. Do not drink. Put your head back a little. Okay. Now can you swallow? Okay. Feel the thyroid isthmus rise under the fingers as the patient swallows. Now you have to displace the trachea to the right with fingers of the left hand. Now with the right hand fingers, you have to palpate laterally for the right lobe of thyroid. Now examine the left lobe in a similar way.
Hello doctor, let's start the examination of posterior thorax beginning with the inspection. Standing in a midline position behind the patient, note the shape of the chest and how the chest moves. Note the deformities or asymmetry in a chest expansion. Note the abnormal muscle retraction of the intercostal spaces during inspiration, most visible in the lower intercostal spaces. Note the respiratory movement or on one or both sides or a unilateral lag in a movement. Next we'll go for palpation. In palpation, identify the tender areas. Palpate any area where the patient reports pain or has visible lesions or bruises. Note any palpable crepitus defined as a crackling or grinding sound over bones, joints or skin, with or without pain, due to air in the subcutaneous tissue. For chest expansion, place your thumbs close to the patient's spine at the level of 10th rib and spread your fingers slightly across the lateral thorax. Ask the patient to inhale and exhale deeply and fully. See the distance between your thumbs. The distance between the thumbs normally is about 5 cm. Next, we'll systematically palpate for tactile firmities by asking the patient to say 99. Feel for the vibrations of tactile firmities. Palpate and compare symmetric areas of the lung as you identify and locate any areas increase or decrease absent firmities. Let's continue the examination by percussing the chest in a systematic manner. Percussion is one of the most important techniques of physical examination. Moving down the thorax and going from side to side as demonstrated in a lateral pattern. Listen to the intensity, pitch and duration of your percussion notes and note the sense of vibration. Identify the type of notes you are hearing. Normal lungs are resonant. Next, ask the patient to take the full inspiration. Measure the diaphragmatic excursion. Excursion is usually 3 to 5 centimeters. And absent descent of diaphragm can indicate pleural effusion. Lastly, let's go with auscultation. It is the most important examination technique to assess the airflow. It involves listening to sounds generated by breathing. To To auscultate, use the diaphragm of the stethoscope, moving systematically from side to side in lateral pattern, comparing breath sounds in symmetrical areas. Listen to the duration, pitch, and intensity of the inspiratory and expiratory sounds to find what kind of breath sounds you are hearing, and note any added sounds or adventitious sounds. Normal vesicular breath sounds are soft, low pitched. They are normally heard during inspiration and can heard over most of lung fields. Bronchial breath sounds are harsher, louder, and higher in pitch than vesicular sounds that can heard over trachea. Bronchovesicular sounds are often heard in the first and second spaces anteriorly and between the scapulae posteriorly. They have an intermediate pitch and intensity. Adventitious or added breath sounds are superimposed on usual breath sounds. Detection of these sounds are an important goal of your examination. These includes crackles, wheezes, and rhonchi. Crackles are intermittent, non-musical, and brief. Fine crackles are soft, high-pitched, and very brief. Coarse crackles somewhat louder, lower in pitch. Wheezes and rhonchi. Wheezes are relatively high-pitched with hissing and or shrill quality. Rhonchi relatively low-pitched with snoring quality. Thank you.
Hello, this is Scientist Stephen Marvin. For the cardiovascular system, first I'll proceed with the jugular venous pressure and position. First, I'll wash my hands. After positioning the patient in an examining table with the elevation of about 30 degrees from the horizontal, I turn his head slightly to the left, illuminating the right side of the neck obliquely with the pen light, noting the top level of the venous position. Measuring the jugular venous pressure and the central venous pressure, I read the vertical distance of ruler 1 and at 5 cm, that is the distance from sternal angle to right atrium to get the CVP. Here I use the right thumb to palpate the right carotid artery and the right second and third fingers to palpate the left carotid artery. I use the diaphragm of the stethoscope to auscultate both the right and left carotid artery. After observing the precordium and locate the apex beat or apical impulse, I shine the pen light tangentially on the precordium and locate the apex beat. I place the finger pads of the second and third digits over the visualized apex beat and note its amplitude and rhythm. If the apex beat is not visible, I palpate by laying the palmar aspect, and if it's still not visible, I palpate with the patient in the left lateral decubitus position. Once palpated, I mark it with an X. I determine the distance in cm from the mid-clavicular line to the X mark. For the thrust or lift and heave, I lay my right hand over the left lower sternal border with the fingers over the apex to feel for the thrust or lift. For thrills, I apply the palmar base of my fingers over all the valvular areas against the intercostal spaces parallel to the ribs to feel for thrills. Here I count the heart rate and identify the rhythm. I place the diaphragm of the stethoscope over the apex and count the rate per minute, and the rhythm is regular. Here the S1 is more intense over the apex and S2 is more intense over the base. Place the diaphragm over the pulmonary area and ask the patient to take a long deep breath and towards the end of inspiration, and the splitting of S2 is normal and fixed. With the patient lie on the left lateral decubitus, I place the bell of the stethoscope lightly over the aspect and listen for the possible S3 and S4. I start from the base over the aortic valve region and inch gradually to the pulmonic valve area and downward to the tricuspid area and laterally to the mitral valve area. So with that, we have done with the examination of the cardiovascular system.
Inspect the symmetry, color, lesions, scars, masses, bulging flanks, peristaltic waves. Notice the umbilicus whether it is flat, inverted or everted. Auscultation. Auscultate all the four quadrants to listen for vowel sounds. Press the diaphragm firmly for gurgling, burbling or popping sounds and for possible bruit. Percussion. Randomly percuss all the four quadrants to detect the air-filled or fluid-filled structures. To measure the liver span, start at an area of tympani below the level of the umbilicals along the right midclavicular line. Percuss upwards towards the liver. Then mark site where the sound changes from tympani to dullness. This is the lower border of the liver. Start an area of resonance just above the level of third or fourth intercostal space. Percuss downward and mark the site where the sound changes from resonance to dullness. This is the upper border of the liver. The total span of the normal liver is quite variable depending on the size of the patient, between 6 and 12 centimeters. Percussion of the spleen. Percuss along the left mid-axillary line starting from the area of resonance on the 8th intercostal space down to the 11th intercostal space. Listen for dullness. Detect presence of ascites, fluid wave. Place the palm of your hand on the one flank, then percuss the opposite flank using the other hand. Feel the impulse transmitted through the fluid into your palm. Shifting dullness. With the patient supine, being percussion at the level of the umbilicals and proceed downward laterally to the right. Mark the point on which the sound changes from tympani to dullness. Then ask the patient to roll in the left lateral decipides position and repeat percussion, beginning at the marker area, moving downwards the umbilicals. Light palpation. With the fingers approximated, press the finger pads gently into the abdomen with a dipping motion to a depth of about 1 centimeter. Deep palpation. Double-handed technique. This is done when the deep palpation is difficult, like an obesity, increased muscle tone, and when the target organ is deep. Palpation of the liver. Place the right hand on the right side of the patient's abdomen, parallel and lateral to the rectus muscle with your fingertips, then below the lower border of the liver dullness. Hooking technique. This is helpful especially when the patient is obese. Hook your fingers around the costal margin or below the border of the liver dullness. Palpation of the spleen. Stand at the right side of the supine patient. Lay the palm on the right hand on the abdominal wall in the left upper quadrant and place the tips of the approximated fingers just inferior to the rib margin along the left inferior axillary line. Place the palm on the left hand on the mid-axillary region of the thorax, with the fingers curling posteriorly to support the thoracic wall at the 11th and 12th ribs. Rebound tenderness. Press the tips of approximated fingers on the right hand gently and deeply. Then suddenly withdraw your fingers. Soya sign. While in supine position, place your hand immediately proximal to the knee. Ask the patient to flex the thigh against resistance. Obturator sign. Flex the patient's hip and the knee at the right angle. Internally rotate the hip. This will stretch the internal obturator. Ask the patient to take a deep breath while gliding the examining fingers upward. Watch the patient's breathing and take the note of degree of tenderness.
Start the examination by inspection. Inspect the contour of the shoulder and shoulder girdle, clavicles and scapulae and the surrounding musculature for any muscular atrophy, swelling or deformity. Palpate the joint spaces, bones and muscles. Note for tenderness, crepitations and subluxations. Begin medially at the sternoclavicular joint and trace the clavicle laterally with your fingers. Then follow the bony spine of the scapula laterally and upward until it becomes the acromion. With your index finger on top of the acromion behind its tip, press medially with your thumb for the coracoid process. Palpate the biceps tendon in the intertubercular bicipital groove. Check for tendon tenderness. Examine the subacromial and subdeltoid bursae and the ascites muscles. Range of motion. Forward flexion, hyperextension, abduction, adduction, external rotation, internal rotation. Special maneuvers. Crossover adduction test, Apley scratch test, knee impingement test, Hawkins impingement test, drop arm test, empty can test, infraspinatus test. Start the examination by inspection. Inspect the dorsal and palmar aspects of the hands and wrist and note for swellings and erythema over the joints, deformities, nodules and body enlargements, and muscle atrophy. Palpation. Palpate the joints at the wrist, metacarpophalangeal joints, interphalangeal joints, and note for swellings, bogginess, tenderness, and body enlargement. Range of motion. Radiocarpal joint with the elbows flexed at 90 degrees and fixed at the waist with palms down. Flexion, extension, ulnar deviation, radial deviation. 2nd to 5th metacarpophalangeal proximal interphalangeal and distal interphalangeal joints, flexion, extension, abduction, adduction. First metacarpophalangeal and interphalangeal joints, flexion, extension, abduction, adduction. Special maneuvers to test for carpal tunnel syndrome, Tinel sign. Phalanx test.
Inspection. Inspect the dorsal and palmar aspects of the hands and wrist and note for swellings, arrhythmias, deformities, and muscle atrophy. Palpate the radiocarpal joint. The palpation of metacarpophalangeal joints. Interphalangeal joints. Radiocarpal joint with the elbows flexed at 90 degrees, fixed at the waist with palms down. Flexion of the radiocarpal joint, which is 90 degrees, and extension of the radiocarpal joint is 70 degrees, and the ulnar deviation, which is 55 degrees, and the radial deviation, which is 20 degrees. Flexion, make a wrist, and now extend the fingers, and now abduction and adduction. Flexion of the thumb and extension of the thumb, abduction and adduction of the thumb. To perform this test, tap on the carpal tunnel. Tap on the distribution of median nerve from the index finger to the elbow. Flexion of the knee and extension of the knee. Internal rotation of the knee joint and the external rotation of the knee joint.
What is your name and age?
My name is Nutan. My age is 26.
Okay. Today I am going to examine your cranial nerves. These are the nerves that will supply your face. May I have your consent?
Yes.
Okay. Do you feel any pain in your face?
No.
I would like to check if you notice any change in your smell. Kindly close your nose with your finger and close your eyes as well. Can you smell it?
Yes.
What is it?
It is gender bomb.
Okay. Now remove your hands. Now I would like to check your vision. Do you usually wear glasses?
No.
Okay. Kindly put your hand like this. Okay. Now remove your hand. Okay. I would like you to read down as far as you can on the saline sheet by covering your eyes with hands.
EN, DV, ZL, FIONP, QTRSJA, CIPK, LQDW, DEN, ZOCS, AZ.
Okay. Now, if you could cover one eye with your one of your hand. Okay. Let me know when you can see my finger.
Yes.
Okay. Now the other eye. Okay. Now I'm going to conduct another test. Once again, close your eye with your hand. Now look at the finger. Another eye. Now I'm going to examine your lower limb. Kindly sink to the side of the bed. Cross both of your arms and stand up without using your hands. Okay, thank you. Start walking towards the chair. Turn around. You can walk with one foot in front of other, please. Now on your tip toes. Okay, turn around on your heels. Okay, thank you. Now I'm going to test your muscle tone. Relax your legs. Okay. Kindly bend your legs. Another one. Okay, thank you. Now I'm going to test your muscle strength. Kindly lift one of your leg. Stop me from pushing it downwards. Okay, now the another leg. Okay, now kindly lift the another leg. Stop me from pushing it upwards. Okay, the another leg. Nice. Kindly push both of your legs together. Okay, now push it apart. Okay. Kindly bend one of your leg. Okay. Now push your ankle towards you. Okay. The another leg. Okay. Now bend your leg again. Now kick it out. Another leg. Again, kick it out. Okay. Now I'm going to test your toes. Push your toes towards you. Okay, this one. Now push it out. Okay, push it down.
Hi, now I am going to examine your cranial of 5. First I examine your motor function of cranial of 5. Okay. I want to check the temporal and masseter muscles. Before that, you clench your teeth. Now, please move your jaw side to side. Now I will be detecting the sensory function of the cranial of 5. I just place this sharp and dull surfaces on your face. Okay. If you feel sharp, feel sharp. Okay. Close your eyes. Sharp, dull, sharp, dull, sharp, dull. Okay. Thank you. I will be testing the corneal reflex of your eyes. So that I just touch your corneal reflex with this cotton. Okay. Look away from me and look up, okay? Okay. Blinking is normal. This is a reflection for this student. Now I am going to test the cranial nerve 7, that is your facial nerve. Before that, you just cover your mouth. Expose your tongue. I just place some drop of solution on your tongue. You just tell what taste you will feel, okay? Close your eyes. Pull out your tongue. Now go. What taste you feel? Swear. I already inspect your face. It is symmetry and your facial movements are also normal. There is no any abnormalities. Can you please raise your eyebrow? Okay. Half round. Okay. Just close your eyes. I will try to open your eyes. You can't open your eyes, okay? This is 20. this is the test for your muscle strength. Okay. Open your eyes. Okay. Show your both lower and upper teeth. Okay. Smile please. Okay. Buff your both cheeks. Okay. I'm going to test the cranium now. 8. This now is the help of hearing. Okay. I just whispered the some numbers behind you. You just repeat the number. Okay. I will close your one of your eyes. 2, 5, 6, 8, 9, 10. Now I am going to place lightly vibrating tuning fork on the head. Okay. You just try to hear the vibration and tell which side you hear. Okay. Okay. Did you hear the sound? One side or both side? One side. Now I am going to place this tuning fork master on your master one near the ear and the level with the ear canal. You just hear the which side you hear the longer sound. Okay. Did you hear? Oh yeah. Okay. Where did you hear the longer sound? Through here. Okay. Now I am going to examine your upper extremity. Show your hand. Okay. I didn't see any tremors and fasciculations. Okay. I want to see the dorsal inclinosis muscle. It is here. Okay. It is full, so there is no atrophy. I want to see the hypothenar and thenar emissions. The emissions are prominent. Can I hold your elbow? Thank you. Flex your fingers, extend your fingers and flex your elbows also. Okay. Okay. So there is a slight residual tension maintained on the relaxed position also. So there is no abnormalities in the muscle. Okay. This is the test for your C5, C6 nerves. Can I hold your forearm and arm? Okay, it's okay for you. Okay. You just flex your forehand against my force. Okay. Okay. Now you extend your forearm against my force. Okay. Can you please make fist of your wrist like this? Okay. I just press this wrist. You just against my force. Okay. Okay. This is the test for your grip strength. You just hold my fingers as tightly you can. Okay. Okay. Hold my fingers. Okay. For finger abduction, you just palm down your hand like this. Okay. You just spread your fingers like this. Okay. I give the force like this, but you maintain this position. Okay. Okay. Just for opposition of the thumb, you just touch your little finger with your thumb against my force. Okay. Okay. Now I am going to check the abduction of the mid shoulder. Okay. Okay. This is the adduction. Flex. Okay. Extend. Wrist flexion. Radial side. Okay. Ulnar side. Okay. Can you do wrist extension? Okay. Can you do finger extension? Okay. Flex the proximal phalanges.
So hello, my name is Stephanie. I'm a second year student of Perpetual. Can I know your name and your age, please?
My name is Andrena Pala and my age is 32.
So today I will be doing the cranial nerve 9, 10, 11 and 12. Is it okay with you?
Yeah, okay.
So I will start first with the cranial nerve 9 and 10. Do you have any experience, any issues of swallowing or cough?
No.
Okay, so now first I will be inspecting your mouth. Can you please open your mouth? Can you say ah? Okay. Can you please cough for me? So now we will be proceed to the swallow assessment. Here you have to take a sip, take a small sip of water. Can you take a small sip of water? So now I will proceed to the gag reflex. Here I will be using the tongue depressor by touching both of your tongue. Is that okay with you? Yes. Can you open your mouth? Now I will be proceed to the cranial nerve 11, that is the accessory nerve. Here I will test for the sternocleidomastoid muscles and the trapezius muscles. Is that okay with you? Okay. I will be inspect first the atrophy of the neck. Can you please show your shoulder and don't let me push you downward. Okay. And you turn to the right. So now I will be proceed to the cranial nerve 12, that is the hypoglossal nerve. Your mouth, can you please open? Can you open your mouth? You stick your tongue out. Can you move side to side? Okay. So now I will be placing my finger on your cheek and you have to push by your tongue.
Let us do finger and nose finger test. With your index finger, touch it here and do it to your nose. Yeah, like that. Okay. Change your hand. Now let us do rapid alternating test. Now with your palm touch and with your back again touch like that. Do it faster. Faster. Okay. Let us do heel to side test. Put your knee here and run it down to the ears like that. Slowly. Yes. Change your leg. Change your leg. From here, yes, to here. Slowly. Go back again. Okay. Walk across the room normally and turn and come back. Walk. Yes. Turn. Uncoordinated gait with reeling and instability is ataxia. So now let's do tandem walking. Examiner should remain near the patient in case the patient falls. Tandem walking may reveal ataxia that is not otherwise obvious. Walking heel to toe in a straight line called tandem walking. Walking on toes and heels may reveal distal leg weakness. Instability to heel walk is a sensitive test for corticospinal tract damage. Okay. Hop. With one leg, yes. Hop. 1, 2, 3. Okay, change your leg. 1, 2. Can you do a shallow knee bend? Yeah, like that. Change. Okay. Close your feet together, arms at the side. Yes. If the patient stands fairly well with eyes open but loses balance when they are closed, a positive rhombic sign. Okay. First, close your eyes. Yes, this response when you feel a touch. Yes. Yes. Now, I'll test you with something. If you feel a sharp one, say sharp. If you feel a dull, say dull, okay? Sharp. Dull. Sharp. If you feel the vibration. Vibration sense is often the first sensation lost in the peripheral neuropathy and increases the likelihood of peripheral neuropathy 16-fold. Causes include diabetes, alcoholism, and posterior column disease, seen in tertiary syphilis or vitamin B12 deficiency. Testing vibration sense in the trunk is useful when identifying the level of a cord lesion. Yes. Yes. Say up and down when you feel the position, okay? Okay?
Okay.
Up or down?
Up, down, up, down,
Okay. Go to the left side.
up, down, up.
Okay. So, like, I will play something. Just tell me whether that is 1 N or 2 N, okay?
2, 2, 2, 2,
Okay. I'll write something. Just tell me what I want.
1.
Okay. Now, I will touch an area. Just tell me. Just point me. Okay. Lesion of the sensory cortex impair the ability to localize points accurately. Okay. With lesion of the sensory cortex, only one stimulus may be recognized. The stimulus to the side of the opposite of the damaged cortex is extinguished.